Great, Lisa, thank you for the great introduction. And firstly, I just want to take the opportunity to greet all the colleagues that have joined online. And I just hope that this talk is going to help and assist you guys with regards to how we look after patients with asthma. We're going to manage them, and I'll probably be focused mainly on the sort of the mild asthma, but I'm happy to discuss any other of the other steps as we go forward. I'd like to thank the organizers for the opportunity, especially the Clinical Care Platform, as well as AstraZeneca. So just to move on, just some housekeeping rules. Whatever I do say here and share is not really binding to AstraZeneca, and neither will AstraZeneca be responsible for any liability, loss, risk, or personal things which might have occurred as a result of this presentation. I want to move on and just start with the epidemiology. Now, with regards to asthma, the GINA, which is our big sort of guideline body that comes up with all these, updates all our asthma guidelines. Their definition of asthma is that asthma is the most common chronic non-communicable diseases that affects at least quite a 260 million people globally as of 2019. So what is the definition of asthma and what is it characterized by? So asthma is characterized by variable respiratory symptoms, and these could be in a sense such as a wheeze, shortness of breath, a tight chest, as well as a cough. And this is usually accompanied with variable airflow limitation. And that usually all is associated with airflow, with airway inflammation. Now, the thing was, as in your introduction, you've mentioned this, people with asthma often will have periods of worsening symptoms and worsening area obstructions, and that we refer to that as exacerbations, or the layman's term, asthma attacks or flare-ups, and these can be fatal. It's one of the asthma responsible for the most morbidity and mortality in sort of low-income countries, and it's preventable. And particularly, we know now that the use of inhaled corticosteroids plays a massive role in the management of this condition. Now, just to talk about the epidemiology, this is an outdated slide, it's about 10 years old. But even back then, we can see that our prevalence of asthma in sub-Saharan Africa is at least about 15%. Now, it's not an accurate estimate because we do know that obviously with regards to prevalence studies, with regards to asthma in the continent, in the region, we've got paucity of data. But again, as we know from 10 years ago, this was a significant number of people who are afflicted with this disease in our continent and in our country. Now, the one thing that is very sad with regards to that is that when we actually look at, asthma mortality and asthma deaths, you find that most of the mortality and deaths are actually located in the low to middle income countries. And unfortunately, in South Africa, we don't have a great statistics of that. We're the highest mortality rate in 2014. So it's not something to really be proud of, but this is a serious disease. It's a preventable disease. And I think that's the reason why we're having these talks. Now, just to move on to the pathogenesis of asthma in terms of exactly what is the problem with asthma. First, it all depends on the type of phenotype of asthma, and there we talk about eosinophilic asthma, which is a common form of asthma, and there essentially it's a whole immunological milieu of cytokines and which drive inflammation, and the end part essentially is that you've got airway narrowing, you've got swollen lining of your airways, there's excess mucus production, there's bronchial constriction, and that all comes into play in giving you sort of the whole sequelae and the symptoms associated with asthma and associated asthma exacerbations. Now, when we look at inflammation, which is what we actually really want to address in patients with asthma, it's not just only the bronchial constriction that's there. We know that there's obviously inflammation as well, and that's responsible for the symptoms. And the inflammation is the key point here. And it's responsible for the airway hyperresponsiveness, which presents with your symptoms as well as airflow obstruction. And those two are bidirectional, but they do come together, giving you the clinical symptoms of asthma that we've discussed in the preceding slides. Now, when it comes to the clinical management of asthma, Most of the guidelines nationally as well as internationally are modified and come through GINA. So I'll be referring to a lot of through this document that they've come up with. And GINA updates all the guidelines yearly when there's new information that has come to the fore. But just to understand that when we talk about asthma management, it's a three-pronged approach. First, we need to, assess. We need to confirm the diagnosis of asthma. Asthma diagnosis can be quite tricky and can be quite difficult, and there can be other causes, of a wheeze in a patient that one should really consider. But I mean, I think once you've made the diagnosis and you've confirmed and you're happy that actually this is truly asthma, the next part of it is obviously to assess the patient's symptom control. Now, the symptom control is what actually tells us in whether how well your patient is controlled. I mean, more symptoms usually speaks towards, poorly controlled asthma, which usually will speak to, poorly controlled inflammation. And we need to look at obviously what are the modifiable risk factors. There are certain risk factors and comorbidities that we know that can exacerbate and worsen asthma. And the examples of that are, patients who've got, increased BMI with obesity, patients who've got, upper airway sort of issues in terms of septal defects and things like that. So all of those things are things that we should take into consideration when we're assessing symptom control. And then importantly enough is the inhaler technique. I mean, our inhalers is what we give our patients to use when they run into trouble or when they're not running into trouble. And obviously, how is it being used and what's the adherence? And then importantly enough, I think when we do engage patients with regards to asthma management care, is that we need to always just make sure that the patient is central to the care of the therapy that we're going to be suggesting or providing. And in the instance of children, obviously the parents must be involved. I think once you've gone through to the assess arm, from there you need to look at other things. Is there any other treatment modifiers, risk factors that we can do if your patient continues to be worsened and has more comorbidities? Is there anything else that we can address there? And any other non-pharmacological strategies? What's the house circumstances like? Are there any pets? Are there any cats? Are there any carpets? What's the BMI? What's the weight? So all of those are what we call non-pharmacological strategies that we can address to try and actually find out if your patient is still poorly controlled. And then the issue of the asthma medication themselves. Well, I think once you've assessed that your patient has got the correct inhaler technique and they're adhering it to correctly and you're happy with that, the next thing we need to look at the medication itself. Are we underdosing our patient? Do we need to up titrate? And do we need to go up the progressive steps or tracks, which I'll refer to in our coming slides. And in all of this, we need to always keep on continually providing education as well as skills training. And then the last thing or part of the arm is to review the patient. So you've assessed the patient, you've adjusted the medication, then the next thing is to follow up and review. And then again, the most important thing is to look at symptoms. The more symptoms you have, it usually points to the fact that you haven't really controlled your asthma well. And unfortunately, more symptoms beget exacerbations. And that's what we actually really do not want, because they're the significant cause of mortality as well as morbidity. Exacerbations are really bad in terms of from a physical perspective, but also from an emotional perspective. And they also play a role in, sort of major sort of adjusted life, quality of life, essentially inhibitions. People are off work, people in hospital, people miss school. So all of those things we really want to avoid. And the medication themselves are not without any side effects, and make sure that our poor controlled asthma who has side effects and prefers not actually to use therapy. And then we can also use lung functions. Lung functions are important in us diagnosing asthma initially, but also with the follow-up, it helps us to see exactly how our lung functions are with time. Exacerbations, unfortunately, are associated with decreased lung function, and that with time can be detrimental. And that's something that we really don't want to, we're trying to avoid. And then lastly, again, as part of your follow-up and your review process, you want to make sure that your patient is satisfied. And in the case of children, the parents are also satisfied. And I think in conclusion, is just to mention that when we talk about personalized asthma care, it's not really just about medications. There's a whole lot of other issues that we need to really address around the diagnosis as well as the patient, and that not one size fits everything. Now, we are still in the COVID pandemic, and 2020 has been really, really rough. But just prior to that, all of this, Gina in 2019 made a new change with regards to asthma management, and this was unprecedented. I mean, Gina has been publishing guidelines since 1995, and basically, had come up with the statement that now, look, the treatment of asthma with short-acting bronchodilators alone is no more recommended for adults as well as adolescents. Now, for most of you in the audience, and even me growing up, exposure to short-acting beta agonists for patients with asthma was the all and be all, and patients really enjoy the using of their short-acting beta agonists. It's easily accessible and it provides rapid relief. So for Gina to make the statement, it was quite a massive statement, and I'm just going to take you through in terms of what they're currently advising now, and I'm going to give you the evidence in terms of actually, why actually they're advising now. So, as you know, traditionally we've got this new stepwise management with regards to asthma, and initially, step one was just SABA only, and then you move on to low-dose inhaled corticosteroids plus the SABA, and then the combination, and you gradually move up the ladder depending on your patient's symptoms and control. So what we have now since 2019, the new guidelines have actually now, due to the literature and the studies that have been published, have come out to say, look, we actually should be combining the first two steps of asthma, and that now there's two tracks, and then the first track is the track where your controller and the preferred reliever are used at the same time. So we would advocate the use of low dose inhaled corticosteroid, as well as formoterol. So it's a LABA-ICS combination that we now would have. Gina advocates that should be used as the initial management for patients with mild asthma. And then what's important about that is that this is coming from quite a lot of epidemiological studies and data, which have actually shown that the use of short-acting beta agonists on their own is associated with the increased mortality, and I'll go through that. Now, this can be very difficult. I mean, I think for a newly diagnosed mild asthmatic, to start them on this therapy upfront will be easy, and I think that's what we're trying to get new asthmatics on. The difficulty are patients who already had been exposed to short-acting beta agonists, who are long-standing or chronic asthmatics, who are mild, to now try and get them to sort of be able to start using a combination inhaler for as needed. So to counteract that, Gina has looked at it. Okay, there can be a different track, and that's the track 2 that we're looking at the bottom, to say, all right, if your patient is going to use a SABA, they should rather take an ICS whenever SABA is taken. And again, I'll get into the reasons why we've got into that. The other steps are usually straightforward. They're the same. We will increment based on your dosages. So step 3, you go up from low maintenance to medium dose, and then when you get to step 5 to the higher doses. Now, where does this all come from Gina in terms of this new stance, and where does it come from? So I just want to take you through time in terms of the how have we actually started coming to across with regards to our short-acting beta agonists? How do we get to use them? So initially, I mean, the use of bronchodilators, it dates back to 3000 BC. As usual, the Chinese were the first to go ahead, and there was an extract form of something called a flower containing what we call as a Ephedra equisentia, which was containing ephedrine, and it mainly was an indirect stimulation of your alpha as well as your beta adrenal receptors, and then the mechanism of that is worked by releasing a noradrenaline and preventing its reabsorption. So these patients would obviously inhale this, and they'd see that their patients who had respiratory disease or respiratory illness would feel better. It was about the 1900 that things such as adrenaline came by, which were short-acting, non-selective alpha adrenal receptor and beta agonists. And the fact that they were non-selective was just detrimental to the patients, because they also were infiltrating on the cardiovascular system and had quite severe side effects, and usually generally with sympathetic activation and tachycardias. But it was actually around about in the 1960s where the current armamentarium of beta agonists was founded, and salbutamol as well as albuterol, with a short-acting beta agonist, which were selective, and those are the ones, and even the current sort of design had kicked off then around about then in the 1960s. And then from subsequently then we've continued to develop. Now we've got long-acting ones, we've got now long-acting highly active ones, and now we're also looking for an approval of the ultra-selective beta-2 adrenator agonist for asthma. So that's essentially the reason where we all started with regards to this. Now, why change, and what's the problem? Well, as far back as the 1992, there's publications in the New England Journal, and usually from the Canadian data, which has come through saying, look, the use of beta agonists was associated with the risk of death and near death, and that was obviously in Canada, and this was in a clinic in Canada. That's what they noticed. And again, early 2000s, there was also concern that bronchodilator short-acting beta agonists associated bronchodilator tolerance, a rebound bronchoconstriction during regular inhaled agonists, and that was obviously a concern. And more data started to show from the guys in New Zealand as well. I say, look, the effects of a short-acting beta agonist and budesonide on sputum cells, and it was associated with bronchial hyperresponsiveness in asthma. So we've always known that this is a potential problem. And it makes actually asthma care and management quite worse. But it always been there. The murmurings have been there. But GINA hasn't been able to update these data up until 2019, and this is just again a schematic of the various publications of GINA. First one being in 1995, and with various revisions. And again, unfortunately the message hasn't been clear in terms of with regards to the subarm monotherapy, because as you can see, up until 2006 in the second revision, they were still advocating for that. But I think what actually needed to happen is a bigger epidemiological data for us to be able to confidently raise this alarm. And I'm grateful that now, as of 2019, as you can see now, they've mentioned that, look, the combination of the LABA ICS as a rescue medication from first step onwards, and then subarm monotherapy is no longer recommended. Now, in order for GINA to be able to sort of come across and propose this, there's been a high sort of level studies that have been done and been done by most of the guys from GINA, and there's two main important trials which I'm going to refer to in this talk, and the first one is what we call the Sigma trial and the Sigma 2 trials, and these are trials basically which Sigma standing for Symbicort, given for as needed in mild asthma, and they looked at a few things. They look at the inhaled sort of combined budesonide formoterol as needed in patients with mild asthma. So and again, the myth out there is that patients with mild asthma don't have inflammation, so they don't require inhaled corticosteroids. Unfortunately, that's not true. We've seen data that patients with mild asthma who have been biopsied have got evidence of inflammation. So what this paper and the study looked at is that, okay, the combination of the LABA ICS as needed in asthma, how does it work, and what do we put it up against? So I don't want to bore you guys with the details in terms of actually how the trial was run. What I actually really want to focus on is just to understand the trial is that there were actually 3 arms in the trial. And the primary objective actually was to show that the LABA ICS combination as needed is superior to the short-acting beta agonist when you compare the two. And what they used is a LABA ICS combination was budesonide, very low dose, 200 micrograms, for a formoterol combination also of 6 micrograms, and they had them in 3 arms. So the first arm was what they call the short-acting beta agonist arm, or the that arm, and they call that the terbutaline arm, which is a short-acting beta agonist. They use 50 milligrams of that. They put that up against the LABA ICS, which is the budesonide and formoterol. And then they had a budesonide maintenance, whereby patients were on inhaled corticosteroids plus a SABA, and they use tibultely when needed. So they had a 3-arm, and the primary outcome was to actually prove that actually, the LABA ICS combination is superior to just the short-acting beta agonist combination. So what do they do? So what were these patients' demographic? First of all, I think this graph tells us their patients' characteristics. These were patients who had mild asthma, and you're looking at their age. These are young patients. Majority are female. And when you look at the ACQ score questionnaire at baseline, anything more than the higher the score speaks to the more severe, the poor control. So they had also quite high scores. But importantly enough, is a few things. One is that most of these patients had quite extensive bronchodilator reversibility on lung functions, which again speaks to the fact that there's ongoing underlying inflammation, and they had a 15% at least across the studies, across the 3 arms. But I think what's actually quite important is that up to 20% of this cohort of so-called mild asthmatics actually had a severe exacerbation the preceding year. So that again is more evidence that patients with mild asthma are at risk of severe exacerbation. And this is a randomized controlled trial. And these are patients in a trial setup, and at least up to 20% of those patients were actually exacerbations the preceding year. So what do they find? So they looked at the annualized exacerbation rate that characterizes as severe as well as moderate severe when you're admitted in hospital. And clearly what they found is that patients who were on a LABA ICS combination as needed budesonide formoterol and had a much lower exacerbation rate compared to patients who were only in the short-acting beta agonists, and that was damning for the use of short-acting beta agonists. You can see that these patients end up with severe exacerbation, with much higher level of severe exacerbation. And when we compare that to the moderate to severe, while I'm on the severe aspects, the difference between the as-needed LABA ICS combination with budesonide maintenance was really not much. I mean, actually, it was actually even better on the budesonide maintenance, but this trial wasn't actually powered to actually address that question. What they did is that they looked at patients with moderate to severe exacerbations. And again, they found that patients who had needed budesonide formoterol had much lower exacerbation risk compared to patients who were just using the short-acting beta agonist. And again, when they looked at to try actually tease out using the combination plus maintenance, does it have any difference with regards to the moderate or severe exacerbation? As you can see by the numbers, really there's really not much difference to the two. But I must admit the trial for this Sigma 1 wasn't powered to answer that question. So this leads us to the next trial to address this question, and that's the Sigma 2 trial. And what they did in this trial actually now tried to actually answer the question, does the regular use of budesonide and formoterol as needed compared with budesonide maintenance have any effects on severe exacerbation? As I said, the previous trial wasn't able to answer that question. They took this forward with Sigma 2 to try and answer that question. And that's why you'll have 2 arms. In this group of patients, again, it was as needed budesonide and formoterol, 200 mics, same dosage as Sigma 1, 200 mics, 600 mics of formoterol, as well as just budesonide maintenance. And you can see they had close to 2,000 patients in each arm. And when you look at the patient characteristics, again, similar to this to Sigma 1, young patients who've got high ACQ-5 scores, who've got significant reversibility on lung functions. But again, even in this cohort, these type of patients, up to 18% of, almost close to 18% of these patients had a severe exacerbation the preceding year. So what do they find? Well, they looked at the 2 studies, and the 2 arms, and essentially when it comes to severe exacerbation rates, there was no difference. There was no statistically significant difference on severe exacerbations between the formoterol budesonide as needed combination versus the budesonide maintenance. And when you look at the graphs as well, the graphs also confirm that essentially there was no statistical significance between the 2. But however, when you go into the supplementary part of this paper, we get to see a bit more. So when we looked at how the patients felt before the start of the trial to how they felt at the end of the trial, and that was when we based them on your ACQ score at your asthma control questionnaires. The only difference was that the guys in the budesonide maintenance treatment felt a bit better. That's essentially the summary of this data. The guys in the maintenance felt a bit better than the guys who were using the as-needed budesonide formoterol. Now, what is interesting, and most clinicians and even patients would generally, would not really want to use inhaled corticosteroids. It's always a concern of side effects, and when you have two inhalers, patients would generally go with the short-acting beta agonist. Not only does it provide them with good, quick relief, but it also, they would stay away because of concerns of side effects from the inhaled corticosteroids. But interestingly enough, when we compared the two trials and the two therapies in Sigma 2, when you looked at the median daily inhaled glucocorticoid dose, you find that the as-needed combination therapy used significantly less total steroid cover as opposed to the twice daily maintenance budesonide. And those numbers are shocking. You can see that the total inhaled dose was about 65 mics in the budesonide formoterol, as compared to almost 300 mics of glucocorticoid. So yes, the patients felt a bit better, but it also shows that they use a lot of the short-acting beta agonists, and that's something that we can obviously I'll open up to discussion in terms of how we can interpret this. So I think these two trials really have been there to try and highlight the dangers of short-acting beta agonist therapy, monotherapy in patients with asthmatics. It's fraught with a lot of morbidity and mortality. And in moving forward, we need to move forward to encouraging our patients with mild asthma to be going on the combination therapy as needed, as we know that at least with a single combination therapy, your patient is going to address both parts of pathogenesis of the asthma. And that is the bronchoconstriction as well as the inflammation. And yes, as I said, the side effects profile, as you can see with the data, you actually more on the maintenance, more so the side effects on the twice daily budesonide plus solvents and the corticosteroid use. Now, it would be remiss of me to just update on a bit of guidelines with regards to asthma and not talk about the current pandemic and the issues around asthma therapy with regards to the pandemic. Now, initially when the pandemic hit, there were really concerns of our patients with chronic respiratory diseases in terms of with our patients actually be getting negatively affected. Does the medication that they're on, either put them at risk of COVID or do well with COVID? So Gina's addressed this and has looked at a few things. So they've come through to try and ask us, with a few questions, COVID-19 and asthma, and and they asked, there were a few questions asked and answered at the same time. Are people with asthma at increased risk of COVID-19 or severe COVID? And the data is quite compelling. People with asthma do not appear to be at increased risk of acquiring COVID. Systematic reviews have not shown any increase in the risk of severe COVID in people with well-controlled mild to moderate asthma. The next issue, obviously, patients are concerned about are people with asthma increased risk of COVID-19 related death. And these COVID-19 updated guidelines as of April of this year, and studies to date indicate that people with well-controlled asthma are not at increased risk of COVID-19 related deaths. And there's been meta-analysis that showed that mortality appeared to be lower than in people without asthma, actually. But what has been shown is that the risk of COVID was increasing in people who had recently needed to use oral corticosteroids for their asthma, as well as patients who were hospitalized with severe asthma. Again, we can discuss that on the discussion. So what are the implications of asthma management with regards to COVID-19? It's important to continue good asthma management with strategies to maintain good symptom control. So we should not shy away from what we are doing. and to obviously try and reduce the risk of severe exacerbations, as well as minimize the need for oral corticosteroids. Now, oral corticosteroids obviously is what we use for patients who come in with acute exacerbations of asthma. They are fraught with lots of complications, and so we don't want to get our patients to be using that. And have there been more asthma exacerbations during the pandemic? And the answer is no. And the past 2 years, many countries actually saw a decrease in exacerbation as well as influenza-related illnesses. Results are not really known, but it's thought to be due to public health measures, hand washing, masks, social physical distancing. All of those have reduced the incidence of majority of respiratory infections, asthma, and including influenza as well. Now, the question that the other thing else we need to talk about is the issue of, what other advice can we mention for our patients with asthma and their management and COVID-19. It's always important to advise patients to continue taking their prescribed asthma medications, particularly inhaled corticosteroids. And for patients with severe asthma who are on biological therapy, they should continue those or oral corticosteroid if prescribed. Are inhaled corticosteroids protective in COVID-19? We know that the oral corticosteroids are the mainstay of therapy and oxygen is the mainstay of therapy for patients with COVID. One study of hospitalized patients, elderly patients with COVID-19, showed that ICS in those with asthma was associated with lower mortality than in patients without any underlying respiratory condition. We need to make sure that all our patients have a well-written asthma action plan, advising them to increase their control and relieve the medication when their asthma worsens, and take a short course of oral corticosteroids when they're in trouble and have severe asthma exacerbations. When COVID-19 is confirmed or suspected, local risk is moderate to high, and generally we advise patients to try avoid nebulizers. And the reason is that because nebulizers are aerosol generating procedures, and also to reduce the risk of spreading the virus to healthcare professionals, to the healthcare professionals, the patients and their families. We generally advise for if you need to get a bronchodilator, and that's what we've been doing in COVID as well, is that would give the MDIs pressure reduced dose inhaler via a spacer for those guys with mild to moderate disease, not for the severe acute. And we can always add a mouthpiece and mask to the spacer if required. What about COVID-19 vaccines and asthma? Well, have COVID-19 vaccines been studied in people with asthma? Yes. Many types of COVID-19 vaccines have been studied and are being used now worldwide. Are they safe? In general, they are safe, but in patients, just like with any vaccine, at risk of allergic reactions, but those are rare. Patients who have a history of allergic reactions to any of these, the COVID-19 vaccine, depending on which one it is, you should receive a different one from the one that you're having a reaction to. And patients with or people with allergies to food, insect venom, or any other medication can safely receive COVID-19 vaccines. And as always, patients should speak to their healthcare provider if they have any concerns. Follow your local advice about monitoring patients of a COVID-19 vaccination. And the usual vaccine precautions apply. Avoid, if you have a history of allergy, avoid a vaccine that contains any of that. And if the patient has a fever and other infection, needs to delay the vaccination until they're well. And then based on the risk and the benefits with the above precautions, GINDA strongly recommends people with asthma that should be vaccinated up to date with their COVID vaccination, so including their booster doses if available. And what about biologics? These are what we use for patients with severe asthma and COVID vaccinations, and most of them are either given intravenously or subcutaneously. GINA advises that the first dose of the biological therapy and COVID vaccine should not be given on the same day. So that also just to make sure that you're able to decipher which one is causing side effects, if there are effects. Influenza, we need to always keep reminding asthmatics to have annual influenza vaccination. And it's recommended now, the CDC recommends now that influenza vaccine and the COVID vaccine can actually be given on the same day. What about after COVID-19 vaccination? Current evidence from the states show that there's substantial transmission of COVID. People will be better protected, and if they are fully vaccinated, if they wear a mask in indoor public settings, and this will reduce the risk to others. This is, as I said, country dependent, and there'll be different policies, public health policies, and depending on the stage of the pandemic, and Gina will continue to update and advise about COVID-19 and asthma as more of our data become available. So with that, I'd like to thank everybody for your attention, and I'd like to open up the floor for discussions and questions. Thank you.
Superb. Thank you very much, Dr. Mnguni. That was quite empowering, and I think that you have also given us enough time, to have some engagements. Colleagues, yes, do share any questions you have on the Q&A. We are continuing to engage, and if you would like to make a comment or ask your question live, feel free to raise your hand. Let me enable that so that we can deal with it. But Dr. Mnguni, maybe I have few clarifying questions in the meantime, and then we will then go through the Q&A chat and maybe hands as well. I did read somewhere that South Africa has probably one of the highest asthma-related mortality rates or death rates. I don't know if you share the same or you share a different view. And what I wanted to ask is that, are there any specific things that would make South Africa unique with respect to the incidence, the prevalence, but also in terms of outcomes when it comes to asthma care? Thanks.
Yeah, no, yeah, thanks. I mean, it's an unfortunately a statistics that's true, that shouldn't be true. I mean, mild asthma is something that we shouldn't be losing patients because of mild asthma. And it unfortunately is a true statistics, and it's something that we can do to address that. I mean, what we need to do to address and obviously counteract that? I mean, there's a few things. I think it all starts at basics at our primary healthcare. I think when we make the diagnosis of asthma, I think it's a few things we need to highlight to our patients. One, that it's a chronic disease, and that is not going to go away. That, as is shown in the data, that inflammation is prevalent, especially even in the mild disease. And then obviously the use of the short-acting beta agonists. I think, to be honest, Lesego, I've seen this quite a few times in my own clinical practice, where patients are coming in with quite severe exacerbation in the EC, and they're carrying their short-acting beta agonist, which has been empty because they've been using that all the time. Patients obviously have the perception that, I mean, it works faster, it's short-acting, and it provides relief, but unfortunately, they don't address the inflammation. And I think, having those two therapies in terms of your reliever and your controller, I think it's something that I think we've unfortunately put out there to our patients, and I don't think, and I'm glad that Gina's come out, and I'm glad that we can now actually finally address the issue, because majority of asthmatics are going to be between mild to moderate asthmatics, and they can account to at least about 30 to 40% of severe exacerbations, which is an incredibly high number. So I do think that for us to counteract this, to reverse that is one is good advice upfront at diagnosis, and then obviously explain the dangers of short-acting beta agonists. The difficulty, though, is you've got a big cohort of asthmatics who are out there who've been actually using just a short-acting beta agonist. Now, to try and get them to change their practice for many years is going to be a challenge. But we've also got a new aspect of patients that are coming through that we need to actually upfront just address this, and obviously say, listen, allow the ICS, when your patient is on that combination, they will be addressing the inflammation, and they will be addressing their sort of the airflow limitation and bronchoconstriction with the short-acting beta agonist. Yeah.
Cool. So maybe let's start a little bit, where this whole thing starts, because there's Anselm. I know, please, if I didn't pronounce your surname, just forgive me, Anselm. She's talking about the diagnosis, and in your opening statement, you did mention that the diagnosis is also quite a difficult process but she's saying, how do you diagnose asthma? How do you differentiate wheezes from other causes to a specific wheeze where you think this is asthma? What process should clinicians follow? Thanks.
Thanks. Yeah. So thanks. I think it all starts with the history. I think it's very important. And as we talk about, classically patients with asthma will have symptoms in the early hours of the morning. Right, that's classically as your own personal experience. Classically, the guys will have symptoms in the early hours of the morning. So the symptoms I think are quite important. And do you have a family history? Is that mom, dad, anybody else who's got asthma? So that will help you and point you toward that this is probably like asthma. And I think that the big elephant in the room is exclude smoking. This is not COPD rather than asthma, because a patient with COPD can also wheeze. Now, I think once you've got a history, and it's usually with asthma, especially like childhood asthma, it will be younger patients who generally wouldn't have any other comorbidities, and they'll have variable symptoms, and they'll tell you it's seasonal. During seasonal change, during winter, I have a really difficult time. Yet during summer, I'm well. I don't have any other issues. So that obviously tells you that you actually probably are dealing with an asthmatic phenotype. Now, with regards to the wheeze itself, how do you differentiate whether wheeze is due to asthma or due to something else? I think first of all, the wheeze, speaks to sort of turbulent airflow within the airways, and that should be unique and should be bilateral. I think once you start having unilateral wheeze, when you listen to someone's chest and they're only wheezing on the one side and there's no wheeze on the other side, then you need to be concerned that there's going to be a focal problem there. Because the wheeze that you're hearing through your stethoscope is turbulent airflow. So what you're seeing is with asthma, you expect it to be bilateral and quite diffuse. Once it's unilateral, that's usually a clue that actually you might be dealing with something else rather than asthma. So that's the one thing I would say about that. But in general, wheezes are very non-specific. As I say, you can get them in patients with COPD. Your history, your physical examination are the things that are going to help you with regards to coming up with the diagnosis.
Superb. I think this is getting quite exciting. So if then the diagnosis is made, you've mentioned that now the combination treatment is preferred. And I didn't tell colleagues, I think I did, but not directly. I said you work at Kaelicha. I hope colleagues are aware that this is a public institution, because most things are available in private, very few things are available in the public sector. Can you take us through your own process in then initiating treatment? What do you initiate? How do you initiate? And what are some of the precautions that we need to know from a clinician point of view as you start in terms of starting this treatment?
Yeah.
In your context.
So, thanks. I think this. I work at a district level hospital. So that's the up level from a primary healthcare. So we'll see most of these patients if they come from primary healthcare. So so for us, I think once we're confident that this is a diagnosis of asthma, it all starts with just explaining to your patient that this is a chronic disease. It's not going to go away, and just explaining to them what actually asthma is. And I think as clinicians, it's quite important. It's quite empowering that we need to pass on that information to patients, because we empower them themselves, and then they understand what the issues are. And then what I quickly do is, once I've explained everything in terms of the pathogenesis, what the problem is, then I jump into the issues with regards to medication. So I think obviously Symbicort is what we are currently using in my hospital, and that is available on tender now, so it's easily accessible, and that's what was being using in these clinical trials, and then we take them through. What does the medication have? What is a steroid? What is a long-acting beta agonist? How do they work? How must you use it? Very, very important. And when should you worry? The more you use it, we should be very worried that we're already not on top of your asthma. So I think once we make the diagnosis, educate the patient, empower them, then obviously jump on into medical therapy, start therapy, and then from there, we're obviously going to say to them, listen, this is how you use your medication. And then we generally would follow these patients up every 3 months just to see where they are.
I saw an interesting comment. Someone was saying patients like their bronchodilators and they don't take their anti-inflammatory inhalers that much. Can you clarify how the treatments you have mentioned actually eliminate that issue, right? Are we talking, is this a fixed dose, a combination?
It's a combination.
Or how is it taken? Thanks.
It's one inhaler which contains a steroid and a bronchodilator. So that's how you address that. So you know that if they take something, they get in good stuff. And that's what you want. You want them to get the steroid. You want them to get the beta agonist part of it as well. So it's a combination. So which is fantastic.
Can we clarify now? Is this taken daily or what? Because I see a question from Funeka. She says, "What is the role of LAMA in asthma management?" So they are long acting. Okay. What does that actually mean? In terms of how they are used. Thanks.
Okay. No worries. So so it's as needed, right? So this is mild asthma. We're assuming that you are able to carry on with life. You don't have a lot of symptoms. So if you feel tight, you use your pumps. It's as needed as you need it. So that's how we use that, and it empowers the patient again, because the patient will know exactly when they need it. The more they need it, then obviously the concern is, we're not actually on top of control, or maybe we should be upping the dosages. So that's the first aspect in terms of how they actually use that. Now, the issue of LAMA, someone has mentioned a LAMA, as you mentioned, which is a long-acting muscarinic agent. What are their role in asthma? So now LAMAs are actually used for patients with severe asthma rather than patients with mild asthma. There's really actually not very good evidence for the use of LAMA in patients with asthma. It's thought that they have a synergistic effect, that they might assist with the bronchodilation, but the jury still asks exactly in terms of which part that we should be using it. It's the same thing such as the use of macrolide therapy like antibiotics, azithromycin. So we don't have clear data in terms of actually where actually should we be thinking about these therapies. But we start thinking about these therapies, or clinicians will start thinking about these therapies once they essentially are, moderate to severe.
So is there a place for your SABAs, your short-acting? Currently, is there a place for that? Mangisi at the 1846 she's asking, so where will the SABAs be used? Is there a place for that?
Look, I mean, I think if you've got a patient who's well controlled, who's got mild disease, and uses the combination therapy as needed, you're not going to be needing SABAs. I think the only time you're going to be needing SABAs is, your patients will probably say, they probably, and if it's already an existing asthmatic, will say, listen, I actually feel comfortable in using my SABAs. I'm still going to keep them, so yes, you're going to get those patients. So that's why with the track 2, it says that if you're going to use the ICS combination, then if you're going to use a SABA, then you must use an ICS. So we're trying to get SABAs extinct, to be honest. And if you are really well controlled and you're as needed, you shouldn't be, because why do you use a SABA? It's because you exacerbate it. That's why you're using a SABA, and you've got acute airflow obstruction. But if you've been using your combination as needed, you shouldn't be getting to that level.
Maybe let's go back to the issue of diagnosis. Maybe let me ask it differently. When do we do lung function tests? When do we do, your PEF meters? Because someone is asking here, can we diagnose asthma without doing those tests? And please address it at the primary care, because I think the bulk of our patients are probably at primary care. You'll probably see more unstable patients as well. Sure.
So exactly. So I mean, I think the asthma diagnostics depends on your level of care where you are. I mean, at primary healthcare, the issue at primary healthcare is our history of physical examination, plus your peak flow meters. So peak flow meters are absolutely amazing with regards to diagnosing asthma at primary healthcare. So there's a definite role for peak flow meters at primary healthcare level. So that's where we're going to go. Now, lung functions is obviously you need to be at a center that offers lung functions. And generally, at tertiary levels, we generally will deal with patients who've got moderate to severe disease, and lung functions helps us in terms of, quantifying the airflow obstruction. And some patients, will get the classical symptoms. But, when you look at their lung functions are normal. They've got wheezing, the lung functions are normal. That will be a trigger for us, to do something more and move on forward, investigate more. But lung functions, are there just to confirm your reversibility, right? And we talk about, and for lung functions, a significant reversibility is when there's a 12% and a 200 moles increase in your FEV1. But that's, as I said, once you start doing lung functions, you're at tertiary level at the hospital at least. But at primary healthcare, district level hospital, okay, peak flow plus a good history, that will help you with your diagnostic. Yeah, it'll take you far.
Yeah, I see a lot of questions as well about other things, vitamin C, magnesium, montelukast. Would you like to confirm, to comment on other additional things that are helpful or not helpful in this case?
Yeah, look, vitamin C is not something that I think is helpful. I haven't seen any data with regards to it in asthma, so I wouldn't give that. I think it probably makes the clinician feel more better than the patient, because we don't have any evidence for that. So we need to be careful about that. There was a question that came up on ibuprofen, which is a non-steroidal anti-inflammatory. That's quite dangerous because a non-steroidal anti-inflammatory can activate your leukotriene pathway, which can essentially worsen your asthma. So we generally like asthmatics not to have exposure to non-steroidals. So I'd be very, very careful, especially giving an asthmatic a non-steroidal. So I think just be careful on that. Actually, if you can, give them something else for analgesia, rather than a non-steroidal, as I said, because of your activation of your leukotriene pathways. And then the other issue was, montelukast, which is a leukotriene receptor antagonist. Yes, there is a role for patients. Again, moderate disease, we would consider it. But again, it's all about access. And the other issues, does it actually play a role? Does it make a significant difference? And there's not much compelling evidence that it actually does. There is some anecdotal evidence that some patients find relief on it, but it's not really something that we would highly advocate for in most of our patients. But yes, clinicians do use montelukast. Yeah.
Cool. I see a question. I'm not sure how to rephrase it, but the person is talking about patients with high BMIs presenting with some difficulty in breathing, some level of wheezes, but on auscultation, they can't confirm whether this is asthma or not. I guess this is a patient you have to modify the risk factors, but also be systematic around your diagnosis. You can't just take it. I don't know how I don't know what the pointers are around patients with high BMI stock. And then I've switched your video off because the network was a bit slow. We couldn't hear you clearly. Thanks, Doc.
No worries. Yeah, look, I agree with you. I think, an obese wheezing patient, the mechanisms of the wheeze in that patient is multifactorial. But yes, I would start off, again, basics with history. And then when you get to your physical examination, is this a patient not in heart failure? Like, this is not a cardiac wheeze. There's nothing else that's going on. So it's for that patient, I agree that could be tricky to nail the diagnosis. And you probably will need to refer them on to a district level and maybe a tertiary level hospital if your therapy that you've instituted is not getting better. Because, as I said, a wheezing in an obese patient is multifactorial.
Cool. Now, two questions, but let's start with this one. Oral steroids, what did the report say? Because there's a lot of questions about the prednisone, oral, and so on.
Yeah,
sure.
Yeah, look, for our patients with asthma now, we've moved on from the use of regular oral corticosteroids to manage asthma. The role is only in the acute exacerbation. Someone comes in with an acute exacerbation, then we're happy to give them oral corticosteroids. But outside of that, even in severe long-standing asthmatics, the role of oral corticosteroids is really not advocated because of the considerable side effects that these things bring with. Patients become diabetic, patients have a risk of severe infections, patients become overweight, patients have thin skin. So there's a lot of sort of side effects associated. So as a summary, the role is only for patients who come in with acute exacerbations.
Cool. I want to try a hand. Mpomudisane, you were asking about the role of physios. Would you like to ask your question live and maybe give Doc feedback as well?
Okay. Can you hear me? Because I just unmuted myself now.
Yes, loud and clear.
Okay, great. Yes, obviously I'm a physiotherapist and I've just been listening at the management and hoping to hear the word physio coming through there. Yeah, basically I just wanted to know, obviously talking to my fellow doctors here, that do you see the role of a physio being important as well as managing the asthma patient here? And also coming back to having had the doctors saying predominantly females are more affected with asthma. I found that during pregnancy, you find that, pregnant mothers would also be having some form of attacks, and I've noticed that they would be prescribed Combivent, which is Atrovent and Berotec, and oftentimes you find that they tend to have tachycardia due to the Berotec. So I just wanted to hear also from there. So basically, in a nutshell, was just to hear the physio coming in and what is the impression from the doctor's point of view, the role of physio there. Yeah.
Okay, thank you, Mpo. Welcome.
Thanks. Thanks, Mpo. There's always a role for physio with regards to respiratory diseases, right? So we really work hand in hand with our physios. The role, though, depends on the disease profile. So this is a seminar where we're doing chronic respiratory diseases, and I'm sure I'll touch on other diseases somewhere along the line. But for diseases such as COPD, for diseases such as bronchiectasis, the physio is the number one point of care. Not so much so for asthmatics, unless we do think that there's other sort of factors that we need to sort of account for poor control, either overweight or they're obese and all of those things, and how to get them to mobilize. But generally, when we talk about physiotherapy in the lung, it's an important aspect, but not so much in asthma, but in a whole lot of other diseases, which I will touch on. I'm sure I probably will be able to touch on. Now, the issue that you're talking about, pregnancy and worsening exacerbations, that's a real phenomenon. And yes, and what's causing that, right? Patients who are pregnant have usually with the pregnant uterus, they had also risk of microaspiration, and we know that microaspiration precipitates an asthma attack. So being pregnant and having obviously your diaphragm being pushed up by the gravid uterus, predisposes patients to microaspiration, which is itself is a predisposition for exacerbation. So generally, how do we take care of the problems? We take care of the problem generally by giving the pregnant people a proton pump inhibitor, so some omeprazole, some lansoprazole, and that usually takes care of that patient. And all the pregnant patient absolutely love us once you take away the reflux, because it's the reflux that puts them at risk of getting the acute exacerbations. So that's how we address that aspect. I hope I've answered your questions.
Superb. Let's go to Siyabona. You may unmute. Your hand is up. Maybe say something. Siyabona Fihla.
Yes, can you hear me?
Yes, we can hear you. Thanks.
Yes. Thank you, Doc, for the lecture. I wanted to ask, I work in Rustenburg at JST Hospital, which is a level 3 hospital, and we see quite a lot of patients at OPD, at medical OPD, with the asthma, chronic asthma. At our hospital, Symbicort is available, but it's touch and go. Like 1 month, they recently introduced it, so it's still neither here nor there with its availability. And I know you're encouraging us to make the switch from the SABA and corticosteroids to the Symbicort. In a situation like that, how do we maneuver that? You imagine trying to maybe convince a patient to switch over, and then the next follow-up they come and it's not available. Should we then just maybe stick to it until it's available like all the time? Or yeah, that was my first question. And my second question, we also get a lot of referrals from lower level hospitals where exacerbations, instinctively people add antibiotics in the mix. And I know some guidelines say that unless you can prove that there is, community-acquired pneumonia, it's not advised. But yeah, just your opinion on that, and maybe because there are other clinicians working at all levels, just to have like a final say on, the use of antibiotics with exacerbations.
Okay, thanks, Yabona, for two valuable questions. Okay, Dr. Ayanda, you can also talk to how you are maintaining stock in the Western Cape there. Thanks.
Yeah. No, thanks very much, Yabona. Those are two very, very important questions. And I think, yes, I mean, I would say the safest thing for your patients is, I wouldn't encourage a switch if you've got an erratic supply. Because that's just going to confuse the patients, and you're going to lose your patients in terms of wanting to be part of their management. So I do think that if you can't go full on with the switch, you need to obviously just educate with regards to the use of a SABA plus ICS combination. If they're using their SABAs, then they must also be using their controllers quite well. So I think that's something that's how we'll go. And then the other thing also, I mean, Symbicort is available on code. It's a tender. So I think what probably you'll need to do, Siyabona, is to maybe engage with your pharmacy and actually see how we could procure that or anything similar to the effect, which might have based on the data. And I think most pharmacists are actually quite open to actually know that. I mean, the data I've shared is also endorsed by the South African Thoracic Society. So, it's out there. So you've got the data. It's just a matter of now of educating, because what you'll find is that there'll be people within the pharmacy itself who are themselves are not aware of all of this. So I think, I would advise that one, you engage with your pharmacy, and then two, you come up with a way. And if they need data or stuff, just literally you'll get updates on our website in South African Thoracic Society what's been advised. And yes, I wouldn't encourage switching unless if you've got an erratic supply, because I do think that will put patients at risk, and you're going to lose your patients in terms of trying to keep them engaged and wanting to be part of that. Now, the issue with regards to antibiotics and exacerbation, that's another very good issue. We do know that most exacerbations in patients with asthma are viral origin. So and generally with those, we would advocate the use of antibiotics. Antibiotics, I would advocate the use of antibiotics if you've got evidence of a proper going, mnemonic process. Your patient's got a cough, they're productive, they've got asthma as well, they're wheezing, you do a chest x-ray and there's an abnormality. In that setting, yes. But in a setting where the chest x-ray is quite clear, I wouldn't advocate the use of antibiotics because of the risk we run with resistance. Lesego, you've asked me to talk about how do we keep stock on this side. Look, I mean, that's a very difficult issue, and I think it's an issue that needs to come up at different levels. I think now that we've got these guidelines, the first thing that we should be addressing is the essential drug list. That's essentially where we should be addressing these issues, so that once we make it easier in the EDL, then it's easier for people at all levels to be able to prescribe this. And obviously, hopefully the distribution also will be more widespread. Yeah.
Cool. No, I think in your response, the issue of talking to your pharmacist, ensuring that they have adequate buffer stocks, also communicating if there's any stock outs, because as far as we know there's enough supply, especially in many other provinces. So it's a question of how the supply, the ordering, the whole system, if it's not functioning optimally, we are likely to have a number of challenges. Doc, there's an important question from Gilebohile on the Q&A at the 1851. She says, I've put patients on Symbicort and the majority come back requesting to be put back on Astavend and budesonide, because they are finding, some of the inhalers a bit difficult to operate. And she's asking, I hope you're a female, I'm sorry, she's asking, how do you encourage your patients to use these devices, and what initiatives have you sort of worked on in your institution to help patients on adherence, I think, broadly? Thanks.
Yeah, no, thanks. I mean, the issue of adherence is, again, is all about education. It's like, you work at medical outpatients, and you write up a script of Panado, and the patient gets a green one instead of a white one, and then they come back to you and say, actually, you know what, this green one doesn't work for me, I like the white one. So it's actually patient education helps a lot with adherence. I mean, remember, you're asking people who for a very long time have been used to having two different pumps, a short acting plus inhaled corticosteroid, and they've been finding a lot of relief. So it's also a behavioral change. It's a lot of behavioral change that you need to engage on, and I think that's the key. The key is to just hammer, the importance of why you're doing this, and then obviously support with regards to behavioral change. I mean, I have some of these patients myself, who come back and say, listen, I prefer to go back to them. But then when you sit down again and engage with them, say, listen, I hear you, but this is the reason why we've made the switch, and this is the issue. So yeah, I think I would advocate just more education and obviously work on the behavioral change, because that's going to be our biggest thing that we need to sort out.
Yeah, Doc and colleagues, we are going to continue until 15:15. I hope it's fine with you, Dr. Mnguni. If you can give us 5 more minutes, I see there's a lot of engagement. So let's take the two hands. The first one, Gitika Sharma. You may want to unmute to ask your question, and then I saw Dr. Khoza, I think, and then you will be the next one. Thanks.
Thank you, Dr. Mavela and Dr. Presenter. Can you hear me, Doc?
Yes, I can.
Okay. Doc, I've as far as I've known, I'm asthmatic since birth, and I'm from India, and I moved to South Africa in 2003, and I was so bad with asthma in India because of the pollution, and I had certain, some triggers, like some bad smells, like, some strong smells will just make my chest very tight. So this topic is very personal to me, and I would just like to tell you, like, some of my experience, and Doc has also, like, pointed a lot of things that happened to me. Like, I had a seizure, and then I was given Brufen, and that nearly ended my life, the Brufen. So Brufen also, I like, from my own personal experience, what Doc said is not recommended. Then slowly over the years in South Africa, I found that this Montelukast, the mast cell stabilizer, it also helped me with managing my asthma. And then plus I take antihistamine every day, and I stay away from bad odors, and I take my Astavend inhaler. But when the winter is too bad, like I'm in Queenstown, it's a very, very cold place. Then, once in a year, I do get a massive attack where nothing helps. Then I'm in bed and I'm gunned down, and then I need to take something like Dexona injection. I need to go to my physician, and then he gives me a steroid injection. Only then, and I take a week of rest. And then I also take some herbal things like turmeric, honey, and physio, like cupping and proning. So all these things together, and then reflux. What that was really interesting. What I don't remember the name of the doctor who mentioned it, but that is also another major factor in asthma, because when we have a lot of this is all my personal things. Now, I haven't studied the COPD or asthma anyway. I'm a pharmacist, but my personal experience is that whenever I've seen that I've got a very massive acid reflux, then I experience wheezing and an asthma attack. So these are the things that I due to cope with asthma, and I'm no more wheezing anymore like I used to wheeze in India. And my asthma is in control because of this montelukast, histamine, and yeah, my Astavent basically. And stress also plays, I think stress also, and the acid. I'm on proton pump inhibitors most of the time, and I try to reduce my acid levels and my stress levels. So totally, this presentation was very close to my heart, and I'm very, very impressed with all the factors that was included, including acid reflux. That's one of the main reasons that causes that wheeze, I think. So thank you so much, Dr. Mavela, Dr. Presenter, because I was late. I can't remember his name, but very, very powerful presentation.
Yeah.
Very powerful. And physios, yes.
Yeah,
I really have a lot to say for physios, because in asthma, physio also helps a lot. The proning and the cupping and the applying of eucalyptus oil or any of these menthol things, and taking a hot bath. So this is all. This is how I, keep myself, my asthma under control. I don't know. I hope it helps to other people. I hope it.
Yes.
Yeah, no, thank you very much for that. That was great, and I think this is what these sessions are about: is to educate each other. And you've mentioned most of the things that are quite crucial. And yeah, no, thank you for sharing your story. Really appreciate it. Thank you.
Yeah, thank you, Gitiga. And yeah, it's quite empowering, even for me. Remember, I grew up with asthma, so I can really relate with your story. So thank you for sharing. And I see a lot of love from the audience. 400 plus are still here. So it means the topic is worth their time. We really appreciate that. Dr. Koza, you'll probably be the last hand for today. Colleagues, you'll forgive us. We would love to continue, but it's a series of webinars. Please appreciate it and allow other topics to come as we come back. All right. Yeah. Dr. Koza, yes?
Hello. Can you hear me?
Yes, we can hear you, Doc.
Hello.
Yes, we can hear you, Doc.
Hello, can you hear me?
Yes.
Oh, yes. It's about inhaler technique. In my province, I find most of my patients, about 90%, don't have a proper way. So what I do, I universally prescribe a spacer, but sometimes in the public sector, you can't. Dr. Mnguni, please.
Yeah, Dr. Koza, we couldn't hear half of your question, but the way I understand, you're talking about the technique of using the inhalers and that you are relying on a spacer in your province, which is not necessarily readily available in the public sector. I don't know if there's alternate ways, but yeah, Dr. Mnguni, would you like to make a quick comment on that? Thanks, Dr. Koza. Yeah.
The signal was bad. The question is on alternative spaces, how to get spaces.
Yes, if the spaces, and if there's no spacer, is there anything people can do at home, or because?
Yes. Yeah, I mean, you can create your own spaces, and we've done that. And you can usually take a Coke bottle, either like the 500 ml Coke bottle. And you could put your MDI at the front end, and then you can obviously use that as a spacer. So a lot of patients can actually use can improvise, but there are ways to improvise in terms of getting spaces. Yeah.